A very good evening, ladies and gentlemen. You are all welcome to our month session of the clinical pathological case presentation. We're glad to have you here. We will take the next 3 minutes to wait for more people to log in. Remind your classmates, your friends, someone who you think will benefit from this session, and then we shall be starting soon. You're all welcome. Thank you for tuning in. Okay. Good evening, members, once again. Welcome to this month's session of the Clinical Pathological Case Series. We are glad to have you here over and over again every month. And we hope you learn a lot from our sessions and get better at managing emergencies overall. This month's theme is about pediatric emergencies. My name is Anna Kaguna. I'm an emergency physician currently working with Mulago National Referral Hospital. And I'll be your moderator for the day. And we do have some people Some are in the background. We have Dr. Olinga Daniel. He will be in the chat. So feel free to post any questions, any concerns. He will be available to answer and attempt them. And then we have Nyesiga Mukama Hamson, who is a fifth-year medical student at Kampala International University, Western Campus. He will be our case presenter for the day. We have Banora Deborah Chirabo, who is a student of emergency medicine technology from St. Michael Lubaga Hospital, School of Medicine. And then we have Dr. Popat, who is an emergency physician from Tanzania, and she'll be our expert for this session. Just a reminder, once you're logged in, please keep your microphone in mute, turn off your video so that we can have a better experience around here. And then if you have any questions, we shall ask you to post in the chat. And when necessary, we shall ask you to unmute and ask the question. You're all welcome once again. And at this moment, by 6 minutes past 7, I open this discussion today. Deborah or Hamson? Hamson, you're welcome.
Thank you very much, Madam Anna. I take this opportunity to welcome each and everybody who is here with us today for this case. And I think we start off with the case discussion. So here we have a presenting complaint, which is for a 3-year-old male child who presented with fever for 1 day and generalized jerky movements for 1 day. Yeah, thank you. We can go to.
So thank you, Hamson. And at this point, when the child presented with a complaint, a call was made and the pre-hospital team received this child. So we'll ask Deborah to kindly take us through your journey with this child in the pre-hospital setting. Thank you.
Good evening, everyone. I am Deborah Banura, and this is my pre-hospital care preparation. I was dispatched as one paramedic with one ambulance operator. I'm going to pick one patient that is currently emergent. The equipment that I have with me are communication devices, a patient monitor, IV fluids, and medications, including analgesics and anticonvulsants. And I'll be going with a type A ambulance, which is the advanced life support ambulance. I am Deborah. With me is a patient febrile to touch, presenting with non-productive cough associated with difficulty in breathing. This is a 3-year-old male with a history of high-grade fever associated with generalized tonic-clonic seizures, a non-productive cough and flu for 4 days associated with difficulty in breathing, as reported by the grandmother. So I discovered this boy had secretions in the mouth, difficulty in breathing, warm extremities, and a febrile body. And I managed to administer rectal diazepam to manage the seizures, secured an IV line and gave 300 ml of Ringer's lactate and a paracetamol IV. And I highly recommend continuous vital observations and a review from the emergency medical physician.
Thank you, Deborah, for that brief report of our patient. So now the patient is in the emergency department and The person who received the patient was Hamson. So kindly take us through your approach to care to this child. Thank you.
Thank you very much, Madam Anna. So, as the emergency department team, when we received the patient, we performed our primary survey where we found out that actually airway had secretions, and on breathing, child had respiratory rate of 45 breaths per minute, and SpO2 was 88 to 90% on room air, and with saturation, the child had capillary time of less than 3 seconds. The baby had warm peripheries, dry mucous membranes. The pulse was 140 beats per minute. However, it was of good volume and it was regular. So the blood pressure was 100 systolic and 65 diastolic millimeters of mercury. Then disability assessing with our FPPU was unresponsive. However, the child had body movements at that moment, and pupils were equal and reactive to light. Then we did random blood glucose, which we found out it was 4.6 millimoles per liter. However, there were no obvious focal visits. Our baby was febrile with 38.2 degrees Celsius. However, we noticed no rash, no obvious injuries on exposure.
Okay, thank you so much, Hanson. And at this point, would love Dr. Jamini to come in and give us her thoughts on so far how the patient has presented at this point. If she would have any questions, any concerns, any additional information she would love to get. You're welcome, Dr. Jamini.
Thank you very much, Dr. Anna. Good evening, everyone. So I've heard the case presentation. So from this case presentation, as our chief complaint being fever and jerky movements. So precisely, it seems like this child has been having convulsions. So this is a 3-year-old child, okay, who has fever with convulsion. Probably it's a febrile seizure for 1 day. So here, before even knowing the primary survey, it's important to go through something known as primary assessment triangle. So primary assessment triangle, which is PAT, okay, it's the first form of seeing a patient who arrives at your emergency department. It includes 3 components. The primary assessment triangle, the components are A, B, and C, okay? So A, which stands for appearance of the child. How does the child appear? The tonicity of the child, the consolability, the look of the child, if the child is crying or not. So this will give us a go-ahead on how to intervene. And as we are in the emergency department, we will intervene as we see. The second component, which is B in the primary assessment triangle, is the work of breathing. So as we have seen, the child's work of breathing is increased, respiratory rate being 45. He's having difficulty in breathing. Now, how are we going to assess that difficulty in breathing? So that's a second component, which has a positive finding in the primary assessment triangle. The third being circulation to the skin. Okay, when we say circulation of the skin, we have to check at the skin color of the child and the temperature to assess the perfusion of the child. So the cap refill. Following the primary assessment, why is primary assessment triangle important in a pediatric patient? Is that there are certain signs while missed in a pediatric patient which will hinder our early intervention. So that is why it's important. Before even reaching to a primary survey, we would start with a primary assessment triangle in pediatrics. Followed after the primary assessment, once it's taken care of, we can move on to the primary survey. As doctor has explained that this child was having secretions, okay? So as soon as the secretions were seen, we need to assess, we need to intervene immediately, okay? Following the secretions, we should know that the breathing was poor of this child, yeah? the child was having a respiratory rate of 45, which is very high, and saturating 89 to 90% on room air. So we need to know what are the measures that can be done to help intervene this child before even moving on to circulation. The third component, which was assessed very well, I believe, was dry mucous membrane, which was taken care of at this point. Initially, the baby was given fluid. So one more thing to take care of over here, this is a 3-year-old child. How are we measuring our amounts of fluids and all? We need to know, okay, the body weight of the child in this case. And how are we going to assess that body weight of the child? So we need something called a Broslow's tape if it's available in our setting. So which will give us an estimate of the body weight of the child to be able to give a dose depending on that. Along with that, the disability, the child was unresponsive, I believed, had jerky movement. Okay. The jerky movement of the child was there, and on exposure, the positive finding was the child was febrile to touch. Now, following that, we should know one thing. So fever is a very blind thing. How was the temperature taken? Okay, if we are looking at only fever, it will depend on the way the temperature was taken. So how did we measure the axillary temperature, the rectal temperature, or did we take any oral reading? Because this differs as well. Most of the guidelines does not suggest the use of oral temperatures, though they are more better in comparison to axillary temperatures. However, our guidelines don't allow us to do that anymore due to the risk of infections and all. Now, following said so, I would like to know from the presenter if the child has any previous history of such kind of convulsions.
Okay, thank you, Dr. Jamini. I hope that Hamson is going to attempt that when you come to the sample history. He will tell us the details. Otherwise, she has cited very serious concerns on how was the temperature taken, which you will be able to answer after the poll question. Hamson, prepare to answer some of those few questions after this. So the poll question should last over the next 1 minute. Let's attempt. It should be appearing on your screens now. If it is not, kindly let me know. And it's telling us from the history and primary survey, what are the emergent signs in this child? You can all type. And then shortly, Hamson will be preparing to answer the concerns of our expert. I hope he took note of them. We have a few seconds left, 30 seconds left to close this poll question. I see 13, about 20 people have so far answered. We are 60 on this call. Please attempt. This is a learning environment. Feel free to answer. We shall have a recap of these poll questions. Okay. I would like to bring this poll question to a close in the next 5 seconds. Okay. Okay, so over to you, Hamson. How was this temperature taken? And then you will tell us your history if this child has had a history of convulsions before. And then we shall move to the sample history. Thank you. Hamson? Hamson, can you hear me?
Yes, I can hear you. So according to the concerns which were raised by the experts, on the issue of temperature, we took it using the axilla. So we took axillary temperature, and the issue of conversion Actually, this was the first. The child had never had any conversion. This was the first kind which happened to this boy. I think there are a few concepts I picked. I don't know whether I have forgotten any, but those are the few which I got, and that is it.
Okay, thank you so much, Samson. Moving on to the next section, which should be okay, how did you attend to this child in the emergent area? So, Hamson, over to you.
Thank you. So, after we did our primary survey, as Pat shared with us, we are supposed to identify the life-threatening conditions and we do them immediately. So, with the emergent stage threatened airway because of secretion, by suctioning, also health tilts and chin lift maneuvers. Then, with breathing, they started to tachypneic, and they were turning to hypoxia because of the saturation, which was 88. And so we intervened giving oxygen for face masks at 20 liters per minute. Then on saturation, we had some dehydration because we had dry mucous membranes. And here we intervened by saturating the IV access. Also, we gave IV fruits. Then at the same time, we withdrew samples for lab work. Then on this mental states movements. So here we intervene by positioning the patient lateral position, which you can call the recovery position, and also we gave anticonvulsants. Then we gave IVD10. That was having fever, yes.
Thank you, Hamson. I don't know if you were able to try and get a better network. You're breaking a lot. Maybe you can try to sketch out for good network as you go forward.
Okay. Now?
Hamson?
Yes, am I still breaking or I've tried to
Okay,
network?
is that
So,
better? I tried. Okay, that's better.
Okay. So with some this 3-year-old male was brought in with a 1-day history of high-grade fevers, which were associated with jerky body movements that started in the left arm and left leg, then progressed to the entire body. And equally, this child had a 4-day history of cough, and they developed difficulty in breathing on that day of presentation. Then with history of allergies, there were no known allergies. Then when asked about medications, this child was on unknown cough syrup while at home. And for past medical history, this was the index admission, and there were no known chronic illness. The last meal was taken 18 hours prior to admission, and even switch led to presentation, actually these symptoms were of sudden onset.
Okay, thank you, Hamson. Now we open up this to the audience over the next 2 minutes. Are there any concerns? Is there something you'd love to know about the case in point that we have up to where we've reached? Yes, feel free to post in the chat. Dr. Olinga is available to attempt to your questions, and then we shall give opportunity to only one person to unmute and make a question. Thank you. Okay, since I don't have any questions so far, I have a question from Mary. Why did you choose to give a simple face mask for this child? Hamson, would you like to attempt to that?
So we opted to give this simple face mask because we want to give good liters of oxygen, and which could not these are prongs. So we decided to use a simple face mask. We can administer some good amounts of liters of oxygen because it was hypoxic, and given that the child was convulsing, they a lot of oxygen to prevent the hypoxia.
Okay, thank you. We have some more questions in the chat, and Dr. Olinga will attempt to the remaining ones. We are going to move on. I hope, Hamson, you keep trying to find better network, because at some point you break, at some point you're okay. Yes. Dr. Jamini, is there something more you'd love to express as any other thought aside from what you had earlier? This is over to you.
Okay, thank you very much. So there are a few things I would like to pinpoint at this point. There are many questions being asked. So I think a lot of things have been touched by Dr. Hampson. There are few things in terms of the use of face mask. As an expert, this child was in severe respiratory distress, severely tachypnic. Instead of even a face mask, if I had to use a non-rebreather mask, I would have gone through that. Why is that so? Because a face mask would provide a bit of a peep to the patient and it would help in the distress, and then I could have weaned off. So certain interventions that should have been mentioned. On the airway, he mentioned that he did suctioning of the secretion. Small things like the use of the suctioning device. Okay, what did he choose? Was it a flexible suctioning device or was it a rigid one? Second thing, on the airway, after the secretions all cleared or still there were more secretions? That had to be mentioned. And at this point of airway as well, what you had to need to prepare for, since the airway was not fully patent and protected, a double setup intubation would have been prepared on the site just in case if the condition of the child changed throughout, then you had it standby. The next thing on the breathing, he is mentioned on the oxygen giving devices and all, which is fine. On circulation, I think 2 large bore IV lines would have been good for this child. Maybe one would have been for fluids, and if he was not responding well to the fluids, the next one would be used for maybe inotropes if they were necessary. On the other hand, if the child was having the difficulty in breathing and convulsions, other medications would be given from to the other line like D50 and all, D10 I mean, sorry. And in terms of disability, let's just go through this again. On AVPU, he said the child was unresponsive. So this again takes us back to A, okay? That at this point, if this child was unresponsive, he is more likely to go into an arrest, a respiratory arrest, at any point. Since the seizures and the airway is not perfectly secured yet, still we need to prepare our double setup intubation. When I say double setup intubation, I mean we need to have our endotracheal tube on standby, and if in case it fails, then we need to have a plan B. That what are we going to do if the intubation fails? Do we do a tracheostomy? Do we seek for another expert advice like ENT surgeon or whatever? What do we do next after that? On exposure, he mentioned that the child had a temperature of 38.2. Antipyretics were given. Okay, the first and foremost thing, the child's temperature needs to go down. But the most important thing, you need to expose your child from head to toe. Okay, place your child in a cool environment. He also mentioned on placing the child in a left lateral position, which was very important at this point, and starting the child immediately on anti-seizure medication. Again, going back to the point, the weight of the baby is very important and crucial. I know it's very difficult at times to measure weight of a child in an emergency setting. That is why we have something called a Broslow's tape that measures the height of the child, and that Broslow's tape has got weight based on the height of the child, which is a very useful device. And I think it should be available in most of the emergency settings for situations like this. Because most of the times, the mothers or the informants do not have the tendency of knowing the exact weight of the baby. And in pediatrics, our doses are all the time weight-based. I think those were some important things. And along with that, I think on the sample history, most of the things were touched, except there was a thing which wasn't asked, and I think it's very unlikely for most emergency physicians to ask for, is the immunization history. So one of them is an immunization history. Were they up to date or not? Can I have some information from the presenter if the immunization history was taken?
Hanson, are you able to, did you manage to get an immunization history for this child? Hanson? Okay, just maybe to counter answer some questions to give context. In our setting, Dr. Jamini, we do have the non-rigid suction catheters for the pediatric population. So we shall never find them, the rigid ones in the ED, except occasionally in the ICU is when we find the rigid ones, which can be used for intubated patients, but rarely do we use them in the pediatric population. And then, so I would like, Hamson, are you able to hear me? Hamson? We have a question. I think this Dr. Jamin will answer it on our behalf. Can we also use age to estimate weight? I think this person, I understand where this person is coming from. In our setting, most of the pediatrics, we do sort of age weight-based estimation in the event that you're not able to get the history from the mother of the most recent weight taken for a child that is unresponsive. So, Dr. Jamini, we would love to give an insight on that. But
Sure.
shortly before you come in, let Hamson answer the question, and then we get to you, close that up. Hamson, are you able to hear me? Is Hamson on the call? Emma, can you help me find out if Hamson is okay? Dr. Jamini, kindly give us your opinion on the age weight-based assessment for pediatrics.
Okay, so based on my knowledge and many studies showing that age-based estimate to weight is not the best way of estimating the weight of a child. Okay, instead, height-based weight estimation is a better option because not all children are going to develop physically the same way. Okay, there can be 2 to 3 different children of the same age. Let's say all of them are 10 years old, but one can be taller than the other one. So age is not the best way. In situations, it's all right to use it, but it will not give you the most correct estimate to weight. So that's my opinion on that question.
Okay, thank you so much, Doc. So, Hamson, are we ready to move? We now want to, in the interest of time, we want to move to the secondary survey that was done to this child, and then you briefly give us what were your thoughts at the time of doing it all. Over to you, Hamson.
Thank you, Madam Anne and our experts. So with secondary survey, the head and neck was we had blood distension or hepatojugular reflex. The chest exam was mildly hyperactive. We had the coastal retraction and auscultation. We had bilateral fine cracks. Abdomen, normal fullness, it was not descended, it was moving with recession, but soft and tender on palpation, and no megary. The femur capillary time was less than 3 seconds, and there were no injuries or wounds. On neurological exam, post-ictal sleep and drowsiness was present. It took about 30 minutes, but it never improved. No signs of meningism, like neck stiffness, which was negative. The skin was warm, flushed. There were no petechiae popular. We also checked the nutritional status of this baby, and the baby was in good nutritional status, and there was malnutrition. That was our secondary survey.
So thank you so much, Hanson. We're going to have a poll question. It's going to be running shortly over the next 1 minute. Let's respond based on the information that we now have. What are your thoughts on the differential diagnosis? You can feel free to choose any option of these. Well, you're closing this in the next 1 minute. Okay, I can see 28 of us have so far answered, 30. So we're closing this in the next 5 seconds. Okay, so let's closing this poll question. Hamson, you have three minutes to walk us through your differential diagnosis and what workup you did for this patient before discussing the overall management.
Thank you, Madam Anne. So, as per now, our differential diagnosis we have at hand. One, we have complex fibrillar seizures, epilepticus. And the reason why we are choosing this, it's because of fevers, jerky body movements, 3 episodes in 24 hours, each lasting about 8 minutes. Then we also had loss of consciousness in post-ictal phase. Then our second differential is pneumonia, and this is in view of fevers, cough, hypoxia, convulsions, and also meningitis, encephalitis, also fevers and convulsions. Then also acute gastroenteritis with some dehydration, because we saw some signs of of dehydration, like dry mucous membranes. So these are our working differential diagnoses. So from there, we had narrowed down our diagnosis, and we requested for labs and imaging. And one of the labs which we requested, it was MRI-DT. We also requested for CBC, then also requested for CSF analysis. The imaging requested for chest X-ray because we had cough, and also we requested for CT scan and EEG. But we found out that CT scan and EEG, we are not able to do them because they were not around this facility where we are. So we are unable to get the results with these imaging modalities. Yeah, so from there we got our results, and the MRI-DT, we found out was negative, and partly that one helped us to narrow our differential, and we ruled out malaria. Then with CBC, when we analyzed our CBC, actually found out that the significant point which we had here, we had increased lymphocyte number. So we had lymphocytosis as per the CBC. The white blood cells and the neutrophils, they were in normal range. HB was also in a normal range, also the platelets. But what we picked out was the lymphocytes. They were very high. The CSF analysis, the cells were slightly increased. Then the glucose was within the normal range. Also the protein, then the opening pressures. So here, the CSF analysis was almost normal. So we are trying to rule out the meningitis, the encephalitis, and this was the CSF results which we got, which never talked much about the meningitis and the encephalitis. Then with the chest X-ray, we are able to get this image, which I would like maybe our experts or any other person within here help us identify what they are seeing on this chest X-ray. Yes. Yes, maybe we get our expert to help us interpret what they are seeing on the chest X-ray. Then go ahead.
Dr. Jamil, would you love to highlight for the team? This was the X-ray of the child that was done. Would love to possibly guide on the interpretation and your thoughts on this. Thank you.
So basically, this X-ray looks like both the epices are slightly hazy. It's not a very good quality, first of all. It's slightly hazy though in the epices. Probably the child could have aspirated here, probably leading to an aspiration pneumonia. Along with that, maybe there's some addition to that.
Okay, thank you so much, Dr. Jamil. Hanson, yes, we have bilateral opacities. So what do you think? How did you guys interpret it, and what did you manage in this child? We do have 3 minutes to close the investigation, and give us what was your working diagnosis for this child.
Thank you very much, Madam Anne and our experts. Yes, so after doing our our imaging and the labs, we had these working diagnoses, which we went with. One was complex febrile status epilepticus, and this was in view of, first of all, we saw the age of the baby. The baby was 3 years, and also the gender. He was a male. Then family history of seizure disorder. Then high-grade fever of 38.2 degrees Celsius. Then the onset of the seizure, it was focal onset. Then also recurrence within 24 hours. Those were 3 episodes. Then the convulsions were lasting 8-10 minutes. And we had no full return of consciousness between the second and the third episode. So these parameters helped us to rule in febrile seizures, and which we classified as complex, but still we added the status epilepticus because of the no full return of consciousness between the second and the third episode. Yes. Yes, any comment on this?
Hamson, we are going to comment at the end. So just take us through how you managed your differential and how you managed this child. And then we shall welcome our expert to give our opinion on how we took care of this child. Thank you.
Yes, so our second diagnosis was severe viral pneumonia in view of fever, then the flu-like illness with the dry cough. And also the baby had difficulty in breathing, then on hospital, fine crackles. Then also on the CBC, we had lymphocytosis, which was taking us to a viral infection. Then when we did chest X-ray, for us, we interpreted the perihelial infiltrates, which told us much about the viral pneumonia. So that was our second diagnosis.
I'm going to request to skip this poll question in view of time. So I'm going to close this poll question. Okay, let's run it for the next 30 seconds. What are the best emergency care plans for this patient? So let's attempt, and then we close it in the next 30 seconds. Okay, I'm ending this quiz in the next 2 seconds. So far, 30 people have attempted. Thank you, everyone who has attempted. And I'll end this quiz now. No worries, we are going to discuss these things at the end of the session. So, Hamson, kindly walk us through your emergency care of this child, and using in the next 1 minute, discuss for us how you manage this child. 1 to 2 minutes. Yep.
So our management plan, we had done a lot of things in the ED intervention. Maybe the person running the slides, you can go back to our ED intervention. We see what we did shortly.
Hamson, as the slides are running, you can walk us through what you do remember. Okay, that slide is over.
Yes, yes. So with airway, we suctioned the secretions, then also press the child in lateral position, which is the recovery position. Then with breathing, as we had already said, we start the baby on oxygen, 5 liters per minute via a simple face mask. Then we continued monitoring the SpO2. Then with saturation, we secured IV access we withdrew blood samples for investigation, which I've already seen. And we gave fruits at mils per hour of 0.9% normal saline and 5% dextrose in a ratio of 1:1. Then with the disability, we gave rectal diazepam, but we never saw any change. The child continued convulsing, and there we gave phenobarbital, a loading dose of 20 milligrams per kg, and there the seizures stopped. Then we administered 5 mils per kg of D10 porous at a slow rate. After 1 hour and 30 minutes of intervention, the child was responding with voice after also administering our AVPU. Then exposure, we gave IV paracetamol to decrease the temperatures. Then we also exposed the child. Then we also maintained urine output, and we saw it was estimated to be 0.5. So under managed, this was the one which did ED intervention. Then you can go back to our management. So here in ED intervention, we managed the emergent conditions through initial stabilization. Then we also did acute seizure management. Then we did investigations. Then when we go to specific therapy, because of our impression which we had at the end, the viral pneumonia, since it is viral, we just manage it supportively. And already we are giving oxygen, we had given antipyretics, and also we are giving hydration, and also we provided nutritional support. Yeah, basically that was the management plan which we had. Then from here, we started monitoring the child. So this was hospital course after the ED intervention. So day one, specifically, that was when we intervened at the emergency department. Then day two, yes, we can note day two. Day two, this is part of monitoring. So we continued monitoring for seizures, and we never observed any seizures again. Then oxygen was gradually weaned off as respiratory status improved, and SpO2 was maintained at greater than 95% on room air. The child was febrile by day 3. They had good oral intake noted, and also IV fluids were stopped. So neurologic exam remained normal after post-ictal recovery. So the baby started improving. Then on day 4, we were planning to discharge because the child had improved clinically. They were still having no fever, no respiratory distress. Neurological exam was normal. And with us, we had a grandmother and the uncle who joined them later. And we counseled them on the seizure first aid and danger signs. So the child was discharged with antipyretics. Then they were advised on hydration. And we scheduled pediatric OPD follow-up in 1 to 2 weeks. So that was our hospital course for this baby. So,
okay, thank you
Doctor,
so much,
I go
Hanson.
on with.
Thank you so much, Hanson. Thank you, Hanson. I hope I'm still audible to you.
Yes, yes.
Okay. So please go ahead and discuss your take-home messages in the next 3 minutes, and then we shall have our expert give our overall overview of the case. Thank you.
So, okay, thank you. Yes. So our take-home message. Okay. Okay, so our take-home message here, as we have seen, we are trying to manage febrile seizures, which later complicated status epilepticus. So this is it, the febrile seizures, how they are diagnosed, the accepted criteria which we use, and it is here. So
Okay, we lost Hamson and we cannot hear him anymore. However, he intended to give us a take-home message on febrile seizures. And with the way the case has walked through up to this stage, I'm going to request our expert to use the next few minutes, in the next 3 minutes, to just wrap up this case for us and give us her take-home messages and what should be our learning points from this case. Over to you, Dr. Jamini. Please take on.
Thank you very much. So thank you very much, Dr. Anna. And there are a few things I think I noticed which I think would have been important in here. One of them being some lab investigations that I feel would have been added to this. CBC was already done, but let's not forget malaria is not the only tropical disease in the East African peninsula. We also have diseases such as dengue fever, which is very common at our setting as well. Along with dengue, there is something called ESR could have been done. And if the patient is just presenting with fever, since you do not have any picture if it's a viral or it's a bacteremia, then the best thing to do at this point would be taking a blood culture before initiation of any antibiotics. And a CRP and ESR would be of use as well. And the child was presenting with some respiratory distress, so a blood gas would be a very good point of care investigation with a lactate. So it would have given us a better picture on what is happening with the respiratory as well as metabolic phase of the baby with some electrolyte investigation. Since as we know that seizures, one of the causes of seizures, electrolyte imbalances can also lead to that. So it would have been very useful for us. Apart from that, most of the management plan has been sorted out, but just a few things that I would like to highlight at this point is Dr. Hampson had he mentioned that we should start with supportive care, the ABCs, maintaining airway, suctioning and all. So these are the essential step in the first 5 minutes on the arrival of this patient. Following this, after managing and supportive care, it is very high likely to start the patient on benzodiazepines as it was started. Suppose we do not have an IV access, okay, and we do not have a rectal diazepam, then we can also give intramuscular diazepam to a baby. And though it is going to be painful, but if we do not have any other option, then we can initiate that. The next thing that could have been done in the was phenobarbital was loaded, but what was it maintained? So a maintenance dose should also have been continued on the long run to prevent more seizures from happening. And also, the first therapy for anti-epilepsies is also levetiracetam. So it's a good drug to use in pediatric patient, and it has less complications in comparison to diazepam and phenobarbital, the barbiturates. Along with that, the thing I think would have been important was, I think I did not mention one important measure, which is the urine. So there was no mention of a urine analysis or a urine culture. So this could have been very essential in determining that was it only the pneumonia causing it or was there any other source of infection. Let's not forget that there is urine analysis, though it is very difficult in the emergency setting to get a urine sample because most of the settings do not have a catheter to pass through these pediatric patients, but it is highly essential to get a urine sample and test it. For simple urine analysis and a urine culture could have been done. Along with that, if the patient needed intubation or not, we could have had that setting as well. And I feel like most of the things were mentioned. Apart from that, maintenance of sugar was also mentioned. The final thing I would have been interested in knowing is what was the disposition plan of the child? Was the child in as an inpatient ward, or would it be wiser to admit this child to either an ICU setting, or if not ICU setting, then an HDU, high dependency unit, before transferring the child to a normal ward facility? So that would have been an essential information, I think, which would have been mentioned in this presentation. So having knowing all these things, I think there are some pearls and pitfalls I would like to talk about. So the key pearls, as were mentioned, supportive care, providing comfort to this child, okay, making sure that the fever was reduced, the seizures were controlled. Observe the child for at least the next 24 hours. It would have been a wiser option to admit this child to either an ICU, and if we do not have a proper ICU, then at least an HDU, high dependency unit. Very important pearl is to recognize the red flags in this. Now, what are the red flags? Along with the high fever, okay, difficulty in breathing, confusion, if there was any rash, or if the skin color was mottled, pale or gray, so it would have been very important. Now, some pitfalls I think in this was over-reliance on thermometers, as I mentioned earlier. In a hospital setting, we have mostly the tendency of using an auxiliary thermometer, but let's have a bit of knowledge that the auxiliary temperatures are 0.6 degrees lower than the oral temperature, and the oral temperature is 0.6 degrees lower than the rectal temperature. And in this case, most of the time, the most and the best and most accurate temperature measurement is the rectal temperature in pediatric patient. The second pitfall is the use of age in determining the weight of the baby is not quite the best option. And I think many of the students over here have pinpointed that. So I would still prefer using the height to estimate the age, the weight of the pediatric patients, since not all age groups of pediatric patients will have the same kind of weight. But if you rely upon the height, you can get a better estimate. So a Broslow's tape would still be of best use in here. Along with that, I would also like to suggest the use of a pediatric assessment triangle as a baby arrives, since primary survey would have taken a bit longer compared to pediatric assessment triangle, because pediatric assessment triangle focuses on the most crucial aspects in a pediatric patients, which could be more dangerous in comparison to the rest, let's say disability and exposure, which could be taken care of later. And along with that, some final things I would have mentioned would have been also, if the age of the infant is very important over here. So our child was 3 years old. I've seen most of the pupils were asking what was the age of this child. So this child was 3 years old. Okay, in a 3-year-old child who has crossed a certain age, you need to also know what antibiotics can be administered in a child like this. So at certain age, like neonates, it's not too convenient to use ceftriaxone in most of the times, or cefotaxime, while some countries are advocating on that, mostly the African countries here. But if it's a 3-year-old child, then you can do a proper antibiotic regime and you can have proper antibiotic initiation from the start. But still, I would prefer taking a blood culture before initiation of antibiotics. I think that was most of the things that we've cleared here. This was a very nice presentation. Thank you so much, Dr. Hampson. Thank you, Dr. Anna. Thank you, the CBC team, and over to you, Anna. Thank you.
Okay, thank you so much. Thank you so much, Dr. Jamini, for coming up to be part of our session. To the team that has presented, that has been with us. This is the end of our session. I just want us to go through a quick recap of the tests we had. And the first question was from the history and primary survey. What are the imminent emergencies? And many of us chose the threatened airway, the possibility of a hypoxic arrest, and that was the most correct answer. And then, okay, And then we had a question on the differential diagnosis. I think these ones we've gotten them. Child had a complex febrile seizure. And then the third question was on the what are the best emergency care plans for this child? We've all picked them: suction the airway, give oxygen therapy, and then obviously stop the seizure as soon as possible. Thank you, everyone. I don't want to take this session beyond this time. I want to thank Hamson, Deborah, for taking on the initiatives, come and be part of this session today. And I want to put it out there to anyone. If you're interested in being part of these cases, please reach out to our team. You can reach out to Dr. Emma, he's our coordinator, or you can reach out to one of the people that are within your universities. And then we'll be glad to be part, to listen to the cases that you see that are interesting. And then equally would love to thank the team that takes off time to organize this session. We have a lot of them. We want to thank, we have Dr. Bonnie, we have Dr. Jimmy, we have Dr. Emma, we have Precious, we have myself, we have Dr. Olinga. This team takes off time to see it, review these cases, and also prepare with the team before we get to present them. These sessions run once every month, and we are here to learn. So in case you see an interesting case, please share it with us. We are here to learn from each of those cases. And I hope we did a great learning from this session. Thank you so much to Dr. Gemini once again. She's a Tanzanian emergency physician, so we are going international as a CPC team. Thank you once again, everyone. We are glad to have had you here. Have a blessed night. Feel free to log off. Bye.